Welcome to Pharmacology of the Synapse. In the previous video, we examined the components of the endocannabinoid system and how it negatively regulates synaptic function. In this video, we will examine the pharmacology of the endocannabinoid system, its effects on the organism, and potential therapeutic uses. The main botanical or natural source of cannabinoids comes from the cannabis plant. There are over 100 cannabinoid structure compounds in cannabis. Of these, delta-9 THC is the main psychoactive compound in cannabis. It is a partial agonist of CB1 and CB2 receptors. Another compound you may hear of is cannabidiol. It is the major non-psychoactive ingredient in cannabis. Unlike THC, cannabidiol is not an agonist at CB1 or CB2 receptors. It has been found to have negative allosteric effects on CB1 receptors. It also acts on a wide range of other receptors, including serotonin, TRPV receptors, and can antagonize mu-opioid receptors. The effects of cannabinoids in the brain, and here we are referring more so to CB1 and CB2 agonism, is very wide-ranging. There are many behavioral, physical, and nervous system effects which are listed here. The points in red are effects that are potentially useful for medicinal purposes, either causing the effect or inhibiting this effect. For example, increased appetite and anti-emesis, which is anti-nausea, would be useful for cancer patients, and changes in bone density could be useful for osteoporosis. Also, inhibiting the euphoria would be a useful treatment for addiction. Of note, there is no respiratory depression that occurs, which is different from opioids. If you remember from the previous lectures on opioids, mu-opioid agonists cause respiratory depression leading to death. There is no respiratory depression from cannabinoid receptor activation, so respiratory depression does not occur. Focusing on the brain, the wide-ranging effects of cannabinoids are due to the wide expression of cannabinoid receptors throughout the brain. Here is a list of some of the different brain regions and spinal cord locations of cannabinoid receptors and the effects of cannabinoid receptor activation in these regions. Medicinal use of cannabinoids needs to balance the desirable effects versus the undesirable effects. Both CB1 and CB2 activation can cause effects that are either desirable or undesirable, and finding cannabinoid receptor pharmacological tools that can selectively target these receptors will be important. Currently, delta-9 THC and a synthetic cannabinoid nabilone are the only pharmaceutical cannabinoid formulations available in the US. A THC plus cannabidiol formulation is available in Canada. Marijuana is legal for medicinal use in select states in the United States, including here in Minnesota. Some states permit the use of cannabidiol oil, but not marijuana. Recently, in 2017, the National Academies of Science, Engineering, and Medicine released a comprehensive report on the current state of data of medicinal cannabinoid effects. The report found that cannabinoids are effective anti-vomiting agents for cancer patients, effective analgesic agents for chronic pain patients, and effective medications for spasticity in multiple sclerosis patients. Cannabinoids also help improve sleep in patients with some conditions such as sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. These are the only significant findings. All other effects of cannabinoids either have no significant effect or there is not enough data to assess an effect. In general, there is a huge lack of quality preclinical and clinical research on the effects of cannabinoids. Genetic knockout mice that lack the CB1 and CB2 receptors have been made, in addition to knockouts of other critical endocannabinoid molecules like the synthesizing and degradation enzymes. These knockout animals will help in determining the precise role of these molecules in biological effects. Some of the classic effects of cannabinoids in genetically intact wild-type mice are anti-nociception, or analgesia effects, immobility and catalepsy, reduction in activity, and reduced body temperature. So why don't we know more about cannabinoids given their long history in human medical use? It is a combination of regulatory, legal, and political barriers that inhibit quality research. For example, THC is considered a Schedule 1 drug, which is reserved for drugs that have high abuse liability with no medicinal value. Heroin and LSD are also Schedule 1 drugs. This is in contrast to cocaine and opioids, which are considered Schedule 2 drugs. There are also problems with intellectual property of natural products and their derivatives, and the lack of dispensaries that can produce marijuana for research. Despite the hurdles in using THC and marijuana for research, synthetic CB1 and CB2 receptor acting drugs, compounds that inhibit DAG and MAG lipase, and FAAH inhibitors have been developed for research use.